here's the thing. Right now, Medicaid agencies, health systems, community organizations, they're working from different versions of reality, right? A hospital may refer someone to a food pantry, but they may never actually know if that person received any food services. The community organization may provide support, but they have no way of communicating back to the healthcare organization that they actually, provided that service. And meanwhile, we have Medicaid that has limited visibility to either one of those interactions.
Try to fix the current system or reimagine something new? Will healthcare ever serve consumers just like me and you? The power's in our hands, but every side's gotta come together. We want the newer generations to get something better. Until we flip the script and talk about what gets prevented. Until we see the changes permanent as if we meant it. Until healthcare is finally consumer-centered. We've got a lot to rap about.
Welcome back to the leading podcast about how consumer health works. We spotlight how healthcare is being designed, marketed, and delivered from the consumer point of view and profile leaders who are championing the move to preventive care. If you want to understand healthcare both as a builder or operator and as a consumer yourself, this is the place for you. Here's what's going down today. First up, we give a shout out to our previous guest, Dr. Erica Armstrong, who recently announced that HealthX Ventures has invested in her functional medicine company, Root. Then I'm joined by Halima Ahmadi-Montecalvo from UniteUs, who dives deep on the data connectivity that's required if health systems truly do plan to move from sick care to prevention. I'm Jared Johnson. Let's get it. Hey, we're all about sharing good news from our guests and members of the Healthcare Rap community here. So today we're giving a shout out to Dr. Erica Armstrong, who recently announced that HealthX Ventures is investing in her functional medicine company, Root. HealthX explained that they're investing because Root treats the cause, not just the symptoms. Here's how they put it. They said healthcare's spent decades getting better at treating chronic disease. The next frontier is helping people understand and address what's causing it in the first place. Root's building a scalable, employer-focused functional medicine platform that helps people uncover the underlying drivers of chronic conditions through personalized testing, clinical guidance, nutrition, and ongoing support. By making this approach available through employers, Root is expanding access to a model of care that's been historically difficult for most people to reach. As employers search for better ways to improve workforce health while managing rising healthcare costs, we believe Root is well positioned at the intersection of several important trends. So shout out to Erica and the whole Root team, as well as HealthX for announcing this new addition to their portfolio. We look forward to seeing what comes next. All right, everyone, let's get into the flow. Please join me with my guest today. I'm here with Dr. Halima Ahmadi-Montecalvo. She's the VP of Research and Evaluation for UniteUs. We have a lot to talk about here, a lot to dig in. So I want to welcome Halima to the show. Hey, welcome to the Healthcare Rap.
Thank you so much, Jared. I also want to say I'm an adjunct professor at George Washington University Milken Institute School of Public Health. So a lot of what you'll hear will be shaped from that background as well. I teach public health and population health courses, and really happy to be here.
Fantastic. Tell us a little bit more about the work you do with UniteUs and kind of like what that day-to-day role involves.
Yeah, absolutely. So I lead our research and evaluation team. And what that means is I have a team of interdisciplinary, amazing people. We have public health practitioners, we have biostatisticians, epidemiologists, even have a medical anthropologist on the team, which is absolutely amazing. And our main charge is to basically prove the value of meeting health-related social needs. So a lot of our work revolves around showing the ROI or the impact of that work and how that impacts health outcomes, as well as what is that return on investment if we invest in social care and community care.
Fantastic. So I would guess, without being too familiar, that extends clearly into what we think of as rural health, as well as, just kind of regardless of where we're talking about, like these are the same types of projects that you're working on.
Yeah, absolutely. So it just revolves, okay, if we meet people's health-related social needs, like, if we address their food insecurity, their transportation insecurity, housing instability, how does that actually impact their health outcome or their health and well-being in general?
Awesome. Okay. So then that leads me to ask, kind of how you got into this, or in other words, let's put it a different way. Let's say how I've been asking guests lately, which is like if you had to boil down your philosophy about healthcare into a couple of core beliefs, what would that be?
Yeah, I love that framing. So, two things. One is that health happens mostly outside the clinic, right? Of course, clinical care matters, but it's only one small fraction of what actually determines whether someone's healthy or not, right? So, like I mentioned, whether you can get to an appointment, whether you have transportation to actually make it to that appointment, whether you have affordable, healthy food, whether you can find stable housing or navigate complex systems, they often have a lot more impact on your outcomes than that 15-minute appointment with your provider, right? So if your care model only addresses what happens inside clinic walls, you're really solving half of that problem, right? And that's by design. And then the second is really around, and I've been talking about this a lot more lately. I'm realizing that good intentions don't scale without infrastructure. And when people hear infrastructure, you kind of immediately go and think about technology. So yes, technology is a part of it, but it's also about how we define care teams, right? So right now, most health systems, their definition of a provider is pretty narrow, right? They're thinking physicians, nurses, and maybe a social worker for help if we're really lucky. But the people that actually do that connective work, people like care navigators, like community health workers, doulas, midwives, behavioral health specialists, they're often treated as an adjacent to care, right? Not really a part of the care team. They're often underfunded or unfunded altogether. They're disconnected from the data systems that actually track outcomes, and they're excluded from your reimbursement structures, right? So I talk about if we are really serious about addressing what happens outside the clinic, the care team, we need to broaden that definition, and we need to include the people who are actually out there doing this work on the ground. So that's a long-winded answer to your question of my core philosophies. And I think those two ideas are really deeply connected in my mind, right? Health happens outside the clinic, and that we have the workforce that addresses those realities. They already exist. The challenge we have is really building systems that support them, that recognize them, and that connect them as part of that workforce in this bigger care continuum.
Yeah, I definitely see those things as being very related. And when we talk about care outside the clinic, for sure, one of the things that does get talked about in buzzwords for sure, and it gets talked about in depth in the right areas of the industry. Are social determinants of health. I've heard them as social drivers of health. I've heard different terms for it, but it does set the stage for the fact like there are a lot of misconceptions still that healthcare leaders have today about operationalizing anything to do with those drivers, with those social determinants. Are you seeing that? And if so, like what's one of those big misconceptions that leaders still have about operationalizing social determinants of health?
Yeah, I mean, one of the biggest misconceptions that we hear, and I think it's more of a misalignment in what you're actually trying to solve for in operationalizing SDOH, it's that healthcare really approaches this work in a linear term, right? They're thinking screen for needs, right? Identify those needs, make referrals, resolve those needs, and then improve outcomes, and somewhere in there also realize cost savings, right? It's pretty linear. But in reality, that's not how it actually works, right? Addressing social needs isn't really a healthcare activity that happens inside a hospital or a clinic. It's really community work, right? The people meeting those needs are really food banks. They're your transportation providers, your housing agencies, and other community-based organizations. So the very first step is really about relationship building. It's those logistics around how to screen, which screener to use, right? Which screening tools to use and which technology to procure. I think all of those are secondary to the work of establishing trust and establishing those meaningful connections with your community providers. And what I've seen, the organizations that do this work really well and operationalize SDOH, they actually start with that relationship building and with shared accountability. And then, of course, technology becomes an enabler of those partnerships. So, when we think about ultimately operationalizing SDOH, I think it comes down to extending the care continuum beyond the clinic and really recognizing community organizations as essential parts of this work and seeing them as essential partners.
I want to shine a spotlight on a couple of sessions that you recently presented at Vive and HIMSS this year. Can you recap those sessions for us? My understanding is you were talking about creating a common platform for different organizations involved in some of the things you're talking about.
Yeah, absolutely. Those conferences were fun. And I was on a couple of different panels. So I had great co-panelists and co-presenters. On one of those, we had Emily Chen from CMS, which was great to have that perspective. But here's the thing. Right now, Medicaid agencies, health systems, community organizations, they're working from different versions of reality, right? A hospital may refer someone to a food pantry, but they may never actually know if that person received any food services. The community organization may provide support, but they have no way of communicating back to the healthcare organization that they actually, provided that service. And meanwhile, we have Medicaid that has limited visibility to either one of those interactions. So the point I was making and what I was trying to discuss was, hey, we need a common platform that actually creates this shared infrastructure layer where everyone can operate from the same information about needs, about referrals, about services delivered, and about outcomes. And that matters a lot when it comes to sustainability because sustainability is all about demonstrating value, right? So if we can see referral activity, if we can see service delivery and outcomes all in one place, then we're able to answer those very important questions about, are we getting people connected? Are we seeing any improvements in their health outcomes? Are we seeing any reductions in costs, right? Are we seeing any type of cost savings? And in my mind and my experience in this field, those answers are what really moves social care from being grant funded innovation to becoming part of long-term healthcare strategy. And that's what we're aiming for, right? That we want the conversation to become more about creating shared accountability and shared visibility across sectors that historically have been really working in silos. So that's the point I was making in those conferences.
So, okay, so some of the values you were talking about or ways to show value. You mentioned referrals, you mentioned service delivery, health outcomes, reductions in cost. You mentioned a couple others as well.
Community
Out
impact
of
is one. Yep.
community impact, yes, yes, thanks. Do you recall any like reaction to any of those in particular? I don't know if that's how that how that works during a panel session. If you like
Yeah.
can see people's heads nodding or whatever, like if there's kind of a general response to some of those more than others, like where the focus is from the audience or from other panelists when you start talking about those different types of value.
Yeah, I mean, absolutely. The reaction, you see a lot of nods. People are very much excited and for cross-sector collaboration. And the audiences that I've been interacting with, they all agree like, hey, innovation is not our problem, right? We've been innovating in healthcare. It's actually fragmentation. It's that, the data systems are not talking to each other. People are collecting redundant data. People don't have that information about outcomes. So then they cannot connect whether or not meeting somebody's social needs actually made a difference on their health outcomes. So we want these data systems to actually talk to each other and address that fragmentation. So usually the response is very much positive and like, okay, how do we make this happen? And of course, in those two conferences specifically, there was a lot of excitement about rural health, and it was like, okay, what do we do with the $50 billion? How is that going to make an impact with this type of cross-sector collaboration? So a lot of excitement, and I think one thing I mentioned, somebody asked a question about this, like, oh, what is so exciting about this time? There are a lot of things to be excited about. There are also a lot of things to be concerned about, obviously. But one thing is that through this rural health conversation, I think it is starting to surface more and more that, yes, people are agreeing that health actually happens outside of clinics and hospitals. So I think that realization, or at least that acknowledgement, has been nice to see across the board in these conferences.
Yeah, yeah, I agree. And I did see the same thing. I saw a lot of focus on rural health in both conferences this year, which is great. It makes me think about just transformation in general. It makes me think about how health systems, say they want to move upstream. And of course, while we're focused on sick care and treatment, of course we want to move upstream to prevention. That's much easier said than done, just like a lot of the other initiatives we've been describing. Are you seeing real world examples where that's working?
Absolutely. I mean, that's what my team and I have been working on. And one thing that I really appreciate about some of these examples, really strong examples when it comes to in this space, is that they all start with asking the right questions around value and sustainability from day one. One example is the Missouri Transformation of Rural Community Health, or the TORCH program. And what they did, this is really amazing. So the Medicaid state agency came together with and basically had these 6 hospitals serve as hub leads. So they were the ones that were identifying people's social needs, and then connecting them with services through community-based organizations. So there was this really strong connection between health system, or the healthcare, and community services. And not only did they see significant improvements in care coordination, but they also saw some great quality metrics. They saw nearly 20% increase in controlled blood pressure. And this is only since 24. And then they saw an 18% increase in behavioral health follow-up after a psychiatric ED visit. And this one is really exciting. I did fail to mention I'm also a social and behavioral scientist. So this kind of stuff really gets me excited. But specifically around this 18% increase in behavioral health follow-up after a psychiatric ED visit, we know from evidence that people who come to the emergency department for psychiatric issues and they don't follow up post that ED visit, they're 6 times more likely to end up back in the emergency department. So for Missouri Torch to see that type of, increase in behavioral health follow-up, I think is fantastic. And only in, a year and a half or so. The other example is Ballot Health. Ballot Health's community health worker program, they actually reduced emergency department utilization by 25 among people who received social care coordination, which is amazing. And then, of course, and I don't know if you saw this, we had recent findings from North Carolina's Healthy Opportunities Pilot, or North Carolina HOP. This is probably one of the most closely watched example nationally. And what they did was they addressed needs like transportation, food, housing, and interpersonal safety for their high-risk Medicaid enrollees. And the program demonstrated, and these are literally findings from earlier this month, $164 per member per month in healthcare expenditure savings. So the
Oh,
interim evaluation showed $85 per member per month in savings. And this is the final evaluation, and it's $164. That's a huge deal. And that gets somebody like me, who constantly is thinking about ROI, really excited. Because if you think about it, that's 164 times 12 is like, what is it? Like 1968. So close to $2,000 per member per year, right? And that's inclusive of the pilot costs, et cetera. So, obviously I have a lot more examples, but I'll keep it at those three. And then just say that what's really important about these examples is that they're not just as social services being nice examples, right? They're examples of social interventions that actually function as healthcare interventions, right? Meaning that if we make sure that people have transportation, that they have food access, that they have support navigating systems, they're actually better able to manage their chronic conditions. They're better able to stay engaged with care, and they're better able to avoid preventable utilization. And we're really seeing that shift. So that evidence base is really building out, which is exciting for the field of social care and community care.
Clearly, one of the things we tend to ask most guests about is kind of like how do advancements in AI, how do more advanced analytics, how does that impact the work you're doing? How does it change things? Does it make it easier, or is it changing even how health systems are approaching some of these initiatives? What are you seeing there?
So from a population health, public health perspective, I think we're moving from a reactive model to a predictive one. And that's a good thing, because historically, healthcare's actually waited for social needs to become visible to then, jump in and intervene. What I mean by that is a patient misses, they miss multiple appointments. They are not, taking their medications, or they show up in the emergency department. That's when healthcare actually intervenes. And I think what AI and advanced analytics, what they allow for is to do more of risk identification earlier. So I think we're closer or getting closer to a world that can actually predict which individuals are likely experiencing barriers related to transportation or food access or housing instability or any of the other health related social needs before those challenges actually become a health crisis. And that's good for the patients, and it's also good for the health system, right? Because it makes things more efficient. So that said, though, yes, I'm pro AI all the way, but I think it's really important that we're realistic about what AI can and cannot do. Yes, AI can identify needs faster. It can coordinate resources more effectively. So it can be that force multiplier. But what it cannot do is it can't solve those underlying causes of those needs, right? It can't create affordable housing. It can't address the policy decisions or the economic structures that actually contribute to poor health in the first place. So yes, technology can accelerate solutions, but it can't replace policy, community investment, or human relationships, which I think health systems are realizing more and more. And yeah, I think they're, operating within those parameters when it comes to AI. So really cautiously optimistic, and they are seeing some efficiency improvements, et cetera, but also you cannot undermine the human relationships and the community investment.
So true. All right, let's look ahead a little bit. When you think like 3 to 5 years down the road, what do you think the most successful agencies and organizations are going to be doing differently than they are today?
I think organizations will stop treating social and community care as nice add-ons. I think Medicaid agencies, health systems, community-based organizations, they will all have shared governance, shared accountability, and shared data. And I think they'll also be using common standards, like the work that the Gravity Project is doing, to really create consistent ways of defining services, defining outcomes and impact. They'll stop working in silos, full stop. I think that's what I want to see in 3 to 5 years. And then the other thing I really would like to see from organizations is that the ones that win, I think, will be the ones that recognize that all care is healthcare and then build systems accordingly around that. So, not asking for too much. I think these are possible, right? 3 to 5
Yeah.
years.
Yeah. We can imagine, even 6 months ago, there was not a ChatGPT or Claude or Perplexity for health. Like, it's only been 6 months. Like, there's a lot.
We've come a long way. Honestly, things are happening really fast. We just need to keep up with them and, of course, have the right standards and boundaries and parameters. But I think it's an exciting time, honestly.
It really is. All right, last question, Halima. You're with your own leadership journey. Like, what's your advice to fellow leaders in this space? Totally open-ended here, wherever you want to go with it.
Okay. Wow. So I'm a researcher, first and foremost. I will say number one is program design and evaluation design. First and foremost, you need to do those together, right? If you don't know what outcomes you're trying to move, or what data you'll need to actually show and demonstrate impact, you'll be doing really meaningful work for years without being able to prove that that work was actually meaningful. So program design and program evaluation. The second is, again, invest in relationships. I think technology matters, but trust is really what makes systems work. So relationships between health systems, community organizations, payers, and government agencies, that's what ultimately will determine whether referrals actually translate to meaningful outcomes. And then last, and this one is really important, is engage payers early and often. Right? Don't wait until your grant funding is about to run out to then start that sustainability conversation. I think it's really important to bring payers into the conversation from the beginning, share data, define success together, and build the evidence base collaboratively. That way they're not just, your reviewer for that final report that just sits somewhere on a shelf. So, honestly, because I talked about this before, at the end of the day, sustainability isn't about proving that this work matters. I think we all know that this work matters. I think it's about creating the operational and the financial structures that allow this work to continue at scale. And I think that's what, we're trying to work towards.
Fantastic. Really appreciate the time that you've given. And thanks for everything you're doing to make healthcare consumer-centered, and best of luck with everything you have going on.
Thank you so much. I appreciate it.